So welcome everyone who's joined us for session 1A CCC Outreach to Vulnerable Families. We heard the two plenary speakers touch on this briefly in the opening discussion, but obviously reaching families, particularly those that are most vulnerable or most affected by COVID, is a very key discussion for all of our work. Today we have a wonderful moderator, as I mentioned, from Sri Ramachandra University, Dr. Subramaniam, or Suraj, and we have three accomplished panelists, Dr. Makana Nashete, Ms. Sauda Nakonda, and Dr. Maria del Carmen Pamplona. So welcome to our panelists, and we're really looking forward to a great discussion today with all of our participants as well. So on that note, I feel very fortunate to be able to pass things over today to Dr. Subramaniam, who I work very closely with at Sri Ramachandra University in Chennai, India. Dr. Subramaniam is an associate professor at the Department of Speech and Language and Hearing Sciences at Sri Ramachandra and has been leading the community outreach CCC team for many years in partnership with Transforming Faces. So welcome, Suraj. Handing it over to you.
Thank you so much, Courtney. It's been a pleasure to start the session this way. We have got a lot of information from the plenary session. So that has set the stage for this particular topic, comprehensive cleft care outreach to vulnerable families. So that's a point which we are all thinking, talking, and then how are we going to restart? What are the strategies? And then what are all the learnings which we can get from other professionals who are who are working around the world. And this platform is rightly set for all of us to learn, share their experiences. So today's panel, we have three speakers, one from the African continent, two from the African continent, and one from South America. Wonderful people have done a lot of work in their area. The first speaker will be Dr. Mekanan, plastic and reconstructive surgeon from Ethiopia. I've known Dr. Mekanan for a very long time. He has seen different challenges at different point of time during his professional career as a surgeon and working with cleft lip and palate. I think this is a different time for him, and it will be eager to know about what he has learned and what he has done. And we have Ms. Sauda here. We may have a recorded presentation from her. She is a program officer from a rehabilitation unit in Uganda, and from a perspective of program officer, what does the challenge look like? What is her view of reaching out to these families? So we have a perspective of how it is from a surgeon, and then we have a perspective of how it is from a program officer, and we have a perspective from speech language pathologist, Dr. Pamplona from Mexico. So we have lessons from and learnings from these three perspectives, and we have wonderful participants who are lined up in this room. And it will be great to have an interactive session, and then have a lot of learning. So at the end of the session, our objective is to have take-home message for each one of us who are here, and see how we can help each other. That's the primary objective of this session. So we are all set to hear to the first speaker, Dr. Mekanan. Dr. Mekanan.
Thank you very much, Dr. Suraj, for the kind introduction. I would like to thank the Circle of Cleft Professionals for giving me the opportunity to be part of this very important forum. Next slide, please. So I'm going to share our experience in time of COVID on the provision of comprehensive cleft care on outreach basis. And this is outline of my speak. Next slide, please. So as it's mentioned by Dr. Suraj, I'm from Yekati Hospital. I lead the cleft program at this hospital. And this is a public hospital, a large public hospital receiving patients from all over the country. And most of the patients are poor patients surviving on subsistence farming. And the malnutrition is still a problem. The access to transportation, telephone, electricity, and other infrastructures are very limited. And we provide comprehensive cleft care with the support of Smile Train and Transforming Faces. Next slide, please. So obviously, during this COVID time, those poor families who are struggling to survive are more affected by this COVID pandemic and related issues with COVID. Our patients are frequently changing their mobile number. So reaching them using the previously recorded mobile numbers was very difficult. For example, we were not able to reach around 20% of our patients. Access to internet and electricity cuts very frequently, so video-based support was impossible. Public transportation is also challenging. Families often need to stand in queue for hours, and during COVID times, this worsened very much because the vehicle space is reduced and the cost has increased. All cleft surgeries was stopped, and many of the comprehensive cleft care service was stopped as of April. There are hospitals which provide surgery and speech therapy in Ethiopia, but comprehensive cleft care is provided only at a K-12 hospital. Therefore, we thought that we have an obligation to do something. Next slide, please. So we decided, we had a meeting and decided to start with announcement, with informing the public that we are still there and providing the service, but in a different way. And we approached radio FM, Shagar FM, and we told them what we are planning, and they announced it through through their radio. And our mobile number and landline number was posted through media.
Dr. McConnell has frozen here for a moment. We'll give him a second to see if that clears up, and if not, we can switch to the video version.
Yeah, we can wait for a minute, Brittany.
Thanks everyone for your patience. You know, we have people calling in from all over the world, which we're so fortunate for, but as a result, there may be the odd technical challenge along the way.
This is the reality, and this is the situation which different professionals are dealing with in low and middle income countries. So we did want to give a chance to all our speakers to come and present their presentation, but we do have a standby. Yeah.
Wonderful. Welcome back, Dr. McConnell.
Yeah, thank you very much. So we educated the community using the same radio about birth defect, cleft in particular, and service we are planning to do. Next slide, please. So we decided that the speech therapy team and the social worker should take care of this activity. And our landline as a cleft unit was monitored regularly during hard hours. And we were able to provide home-based counseling to increase parental acceptance and also feeding counseling. And we were able to give oral hygiene tips and guidance on some orthodontic guidance. And we are able to also to give home-based speech therapy. And we are able to schedule the sessions to the convenience of the parents when it is possible. Usually this took longer time than when the patients actually come in-person speech therapy. In some cases, we referred patients to the nearest clinic for some dental problem. Next slide, please. So in addition, we are also able to distribute brochures to delivery service providing institutions in Addis. We met some of these professionals and discussed about the situation and informed them what we are planning to do. And the brochures contain our contact information about overview about clefts. They also contain feeding advices. And these brochures were produced in 2 local languages, Amharic and Afan Oromo. And these are the largest languages which are spoken by the majority of Ethiopians. Next slide, please. So using this approach, we are able to reach to 79 parents of cleft patients and able to provide counseling and feeding advice. And 60 parents of cleft patients received form-based speech therapy. And we were able to reach to 16 patients and parents for oral hygiene tips and orthodontic counseling. We were able to distribute 1,700 brochures during this time, and we regularly collected information, how the child is doing, whether he is gaining weight or not, how if there's any change in his speech. So we are doing this follow-up. Next slide, please. So since the COVID issue associated with COVID could be a long time effect, and we don't know when it stops also. So we have to ensure ongoing cooperation of delivery providing institutions to report new cleft cases. And we have to also try to reach more delivery service providing institutions out of Addis. And currently we are able to reach only public institutions, but we have to also include private institutions. We also need to prioritize some of the vulnerable cases for in-person care. And we have to resume in-person care for families who can't travel. Next slide, please. So there are potential risks associated with this activity. Some of the risks are many of the families are living in a small room and crowded. So it is very difficult to find a convenient place and time for home-based speech therapy. That's one big problem. A level of understanding when the families are uneducated is also a huge problem. And maybe the cooperation of other stakeholders may not be there in some instances. So because of this, when there is no in-person contact, for example, demonstration of feeding and so on, the service somehow will be compromised. And because of COVID-related pressure, parents may not seek the service, and this may lead to less coverage. So some of the solutions we propose are, for example, we have to report regularly the activities we are doing. We have to try to choose a convenient time for the families when it is possible. And also we have to resume in-person care for selected families. Next slide. So during this activity, we learned that even though there are a lot of problems, it is still possible to reach the most vulnerable families and provide some care. For example, increase the work on parental acceptance by counseling, which is a huge problem. And so therefore, since we don't know when COVID ends, we have to continue the outreach service using available means and try to reach upgrade.
We'll give him another moment here. Thanks for everyone's patience.
So as we are waiting for Dr. McKinnon, whoever has questions, please start writing the questions and then keep it ready so that we can use it during the interactive session. So many points here started talking about how the services are affected and all of that, and many of us may be facing similar challenges in our environment, and it will be great if it can be documented so that it can be shared in this forum.
It looks like Dr. McConnell may have dropped off and is trying to rejoin. This is just his final slide, so if he doesn't rejoin here, we'll just move on to the next presentation.
Yeah, we can go back during the discussion time.
Yeah, thank you very much. With this, I will finish my presentation. I'm back again.
Oh, thank you, Dr. McKinnon.
Yeah.
Wonderful hearing about the work which has been happening and your experience. We have a lot of questions about in these lines. I think once we finish all the presenters, we'll come back to you and to hear first-hand information from you, Dr. McKinnon. Thank you so much.
Okay, thank you.
Thank you, Dr. McConnell.
Thank you very much.
So the next presentation will be a recorded presentation, which will be played from Courtney, and then we will take points and then we can discuss it in her absence. So there will be lessons from her perspective.
Thanks, everyone. So just a heads up that we did face some challenges doing the recording with South Anaconda. So she has lots of fantastic experience to share, but it might be a little bit quiet or at times slightly difficult to hear. So we really do appreciate your patience and hope that you're able to still get some important lessons from this recording.
Good morning, everyone. My name is Sauda Nakanda. I am a Programs and Communications Officer at COSU. I coordinate the mobilization of cleft patients. COSU Rehabilitation Hospital is a non-for-profit organization that was founded in 2006 with a mandate of restoring ability and preventing disability. At COSU, we provide orthopedic, medical rehabilitation, plastic and reconstructive surgeries. With the support of Transforming Faces and Smile Train, we are able to offer the following interventions to the cleft patients. One, we offer counseling. Most of our patients come with so many issues around stigmatization, and just a click of a counseling session restores their life prior to surgery. We do nutrition rehabilitation for the cleft lip and palate patients. It is around education and boosting their nutrition. Then the other service that we offer to the cleft patients is an assessment by the pediatrician or a surgeon. Before any surgery is taking place, an assessment is done by a pediatrician to determine the next step of rehabilitation. The other thing that we offer to the cleft patients is speech and language therapy. We have a full-time speech and language therapist who is there to help our patients with speech problems. Just to take you through what we normally do for the cleft patients in order to reach out to them. We do awareness campaigns and trainings in the communities, mainly to help them identify, refer, and manage the disability. The other thing that happens to reach out to the vulnerable communities is COSU has a network of partner organizations, as you see, around the country, and these help in referring the cleft patients to COSU. Then what we cannot forget is the community mobilizers who do an important job in transferring the patients to COSU. However, as you know, during the COVID pandemic, the whole world was affected. So was Uganda. So the government of Uganda put in place precautionary measures, including the ban of public transport, to the cleft intervention measures that are in place for the patients. The services were a little bit halted. So when the government released the transport, we decided to sit as a cleft team that is headed by the plastic and reconstructive surgeon, and we decided on a few strategies to try and reach out to the cleft families. Some of these strategies were, we developed community messages that were translated into the different local languages. These run on the different radio stations, mainly around the newly born cleft patients, teaching them about nutrition as they transition to COSU, or Comprehensive Cleft Care. Then, as you see, we printed branded t-shirts with cleft messages and distributed to the nurses, midwives, some people who have authority in the community, and they are the ones who are helping us to refer the cleft patients to COSU. Our team did a lot around availing themselves on phone to the patients, caretakers. This was most significant with the nutrition team that was able to give the numbers, their phone numbers to our patient caretakers, and these patient caretakers called them whenever they had any issue surrounding nutrition. Per our records, we have from the month of April to June, we're able to record 20 caretakers that were reached out by the team around the issue of nutrition. Then we could not forget our mobilizers as well, because they are critical. So we realized there was a gap, so we decided to informally teach them about feeding of the newly born, and we emphasized to them to impart the information with the support of the health workers in the villages where they stay. This helped the cleft patients to keep healthy as they transitioned to COSU for comprehensive cleft care. And when the lockdown was eased in June, some caretakers were able to travel to the hospital for comprehensive care intervention. We were able to give the nutrition packages to those who were assessed and found that they were in need of the packages. Our team was able to revise the transport fare that is given to our cleft patients. This is because when the lockdown was eased, it meant that the public means transport operators were going to operate on half capacity, meaning that whoever boarded a taxi had to pay double. Most of our patients cannot pay even the single transport fare. So as a team, we sat down and revised the transport fare given. On top of this, for those that needed counseling, we encouraged them to come as partners, so we gave them double transport. That is how we have been able to encourage our patients to come for interventions during this lockdown period.
Thank you so much, Courtney, for sharing the video. I think there are lessons from this presentation too, which the presenter is not there, but it will be great to have a discussion on all these points. Very valid points. Many of us may be facing such situation, and many of you may have some suggestions or points which we can take home. So we will wait for the next presenter who is going to give a perspective about the speech therapist from a speech therapist point of view. And she is known for using technology and different models for a long time. And I'm waiting to hear from her what she has done new during this pandemic. Over to you, Dr. Carsona.
Thank you very much. First of all, I want to thank Transforming Faces for having me here and with this opportunity to share and learn from all of you. I am going to share our experience using telepractice for speech pathology intervention. So we have been using different models in order to get closer to the families and to reach all these vulnerable families. And with this pandemic, of course, we have to change all our model. So we all know that patients with cleft palate are at risk for speech disorders, so they will need speech intervention. And for us, as for many countries developing countries, this is a challenge. So, most of these patients are in the lowest socioeconomic status, so they are living in poverty. And more we know that poverty has become a risk factor for speech and language development, as well as for other even cognitive or emotional abilities. And this COVID pandemic has added complexity to this situation because the economic resources, the need to go out, the impossibility to reach the services has added this complexity. So we had to stretch our way to get to them. So 10 years ago, we started the audiovisual project. This project includes narrated stories and songs. The songs were specially designed for the patients. So each one has a corresponding coloring book for visually supporting the audio input. The idea is to facilitate the accessibility to the content in order to be able to focus on articulation. The songs and stories includes all the phonemes affected in children with compensatory articulation, and most of all offers meaningful context for working with speech. So originally they were delivered in CD, and in the storybooks were in a physical way. But right now we are started to deliver via other ways. So next, please. So the objective of the program is to provide families with information and material for stimulating articulation at home. Right now we have around 30 songs for different ages. And with the emergency, the books are being turned into videos in order to facilitate the access and delivery to as many families as possible. So this is an example.
Coca, sientan aquí. Coca, ¿cómo explota? Coca, Coca. Y unas papas, papas, que sientan aquí el... Sientan aquí. Coca, unas papas, unos cacahuates. Coca, unas papas, cacahuates, y calabazas, las tortillas, peras, unos chocolates.
So that is more or less the way we work with them. So we have different options for a choir, and many kids love to be there singing with others. So right now for the deliver, as I was saying, we're not able to deliver via CDs, but now we're delivering the songs via WhatsApp or email. And we find out that these videos are the ideal tool for working online with telepractice. So we have made some studies about the efficiency of the materials, of the use of the materials. And we find out that the use of the materials enhance correction of articulation. Many kids who love the songs are improving their articulation. And I think the main reason is that the material provides structure for working at home or in therapy sessions. So the parents are not told just to work with them in an open way. So they have specific things to do with the materials. So I think the materials can be easily delivered, and they are, this is a benefit for these times of COVID. So as I said, we're using the materials through telepractice. Telepractice is defined as using information and communication technologies to deliver health care services. So when the pandemic started, we started thinking, what are we going to do with our patients? The next, please. So we started to use telepractice, and we know that telepractice has become an excellent option in these times. So we started at the end of March when the pandemic started. At that time, we had 50 patients. The ages ranged from 1 to 40 years. And the patients were distributed in small groups, which we usually do in our in-person sessions. So we had around 10 groups, and we did a pre and post evaluation in articulation. So this study was made in April, so it lasts 1 month. The methodology was made through the whole language model, which we usually do. So we did the therapy, the official therapy, plus different workshops. So we had the storybook reading, which is the main workshop for me, but we also had cooking, the choir, so they were able to sing together. We have writing workshop, we have theater workshop, we have rhythms and movement, and we have art. So as you can see, the kids enjoy very much the workshops, and we also do. So the next one. And as a result, after 1 month, we find out that 84% of the patients demonstrated severe compensatory articulation. And at the end, comparing the pre and the post, we find out a significant improvement in severity of articulation. So I am convinced that we will keep using telepractice when the pandemic is gone, because we are able to reach families from very near, very far places, from Mexico, and we're working also with patients and families from South America and other places. So I think it's a very good tool. So we're also doing a cell phone tablet donation campaign where we ask our families, our relatives, our WhatsApp groups to donate the cell phones and tablets that they have at home and they're not using, in order to reach more and more families. So as a conclusion, I think that the practice can be a reliable tool for improving compensatory articulation in children with cleft palate and for reaching patients in this time of global pandemic. Thank you.
Thank you so much, Dr. Pamplona, for giving this information. As usual, your presentation has some fun and all of that, and that is something what SLPs would always love to hear, and then see whether they can incorporate in this practice. And now you are taking the therapy to home with all these activities. So there are a lot of questions which I have got, and from the 3 presentations. If you're ready, maybe we can start discussing, and then we can take questions from the group also slowly. Dr. McConnell, your presentation was interesting, and one of the important point which you were talking about is malnutrition. How do you think we are going to address, because it is going to add problem during this pandemic? What are the suggestions to address malnutrition now?
Yeah, yeah. Malnutrition is it's a problem even before, and during COVID, obviously it is obvious that it is going to worsen. So now there are some efforts to get support from small train transforming phases for nutrition, but obviously this cannot be a long-lasting solution. Okay. I think we have to teach parents to use the available materials to tackle malnutrition. I'm sure India has a lot of experience in this. I have visited some of the places when I was in CMC. They provide nutrition as well as they teach the parents to prepare nutritious food using the available materials. So for this, but it needs a separate place to educate the parents. But obviously malnutrition is much worse this time because there is no work. Many people like daily laborers are not working because many of the building workers have stopped. So it is these people are even before they are at risk, now they are more at risk.
Yeah. My next point was
you can share your experience, Suraj. I know you have outreach experience, and also some of the outreach experiences we learned from you.
yeah.
So, and the nutrition, I'm sure you have a lot of experience.
Yeah. Well, I'll be happy to share that, but it's great to hear from you because you have a different information for us. So my next question was in the same line. How do you think people will be prepared to come for a follow-up surgery? Because there are so many babies who are born in Ethiopia. What do you think as a cleft care team you are trying to do to bring them back to the hospital?
Yeah, it's going to be really challenging because people are now scared to come to the hospital, even for killing diseases, like for example, for follow-up for diabetes mellitus, for chronic illnesses. They are scared to come to the hospital. So I think this is going to be a problem for a long time. But at the same time, when we are teaching about telephone-based counseling and so on, at the same time, we have to also to include now you can also come safely to the hospital. The presenter from Corso, I think if I heard her exactly, she said providing T-shirts was helpful to bring patients back. I don't know if I understood exactly, she can correct me. But I think like providing PPE may be better to the families. Like now come to the hospital, we will provide you with PPE. It will be safe. You will not get any problem by bringing your child to the hospital. And when you go back, you will get transport support and also personal protective equipment. So this way, I think families could be encouraged to come to the hospital.
The other point which you made, which is very important for me, when I use the word CCC, and I really take the real meaning. How important it is, because you have used the speech therapist and the program officer to communicate information about speech, dental, oral hygiene, and all of that. How important it is during this pandemic for each professional to understand their other professional role and to be able to give information. Was it really helpful in your case?
Yeah, what we did was, we have a landline at our cleft unit. So the orthodontist gave a written instruction what to inform to the parents. The social worker is doing her own job, but the social worker at the same time, she has got instruction, a written instruction, which information to pass to the parents. And she is collecting information from the parents, and also the written instruction which are provided by the orthodontist, she's passing that information directly. In fact, there will be knowledge exchange during this time. She will have some information about oral hygiene when the orthodontist is telling her to pass this information to the others. She might have some understanding about the orthodontics. So as you said, cleft is not a single profession, it is a multi-profession. So each profession, each part of the team should understand, at least have some vision about what the other colleague is doing about that particular patient.
That's very nice. Dr. McConnell, can you please tell some more information about using radio as a media?
Yeah, radio, well, it is not ideal, but when there is nothing, that's a very important thing, because we use radio to communicate to the community that we are still there. We are providing the service. We are providing the service which we used to provide in person, but now through phone call. So like if a cleft child is born somewhere, the issue here in Ethiopia, I think, is the same in many developing countries. Parental acceptance is one big issue. And if the child is not accepted, they will not bring the mother will not be able to bring to her breast to feed the child. So the first thing to do is the counseling. So this can be done through phone call. Comfort the parents, like, this is a congenital anomaly which can be corrected, but it needs your effort. So don't worry. We did a lot of such cases, and this child will be all right. Don't worry. So this comforts the family, and then they will accept the child. If they accept the child, then you can feed your child. There is no problem in feeding, but during feeding, do the following things, like keep him upright, try to make the bottle appropriate, and so on. So this is a big help for a mother who was pregnant for 9 months and didn't know what type of child she's going to have. And the information is just at delivery. In more than 90% of our cases, they don't have perinatal ultrasound. They don't know what is the outcome until the delivery time. When the delivery time comes, when they see this child, it is a shock time. And this is very important to comfort them that this is a repairable condition. Don't worry, this can be repaired. And read this brochure, it tells you what to do. So this really changes many things.
Okay. So there was yes, Dr. Shifra, we will come back to you. Just a minute. Dr. Mekanon, one last question from my side. There is a very nice point which was suggested by Dr. Hall about mobile and then communicating your needs to service provider. I don't know really how practical or possible it is, but there is a possibility to negotiate. But how are you going to address these problems, of not being able to reach the family?
Yeah, that's really a difficult thing. Dr. Maria, I think, mentioned about providing mobile phone. Is that what she said? The problem is someone have a mobile number. When they come to your unit, obviously you record their details and contact information. They will give you phone mobile number. It will be active for some days, and then they changed it. Maybe it disappeared. It is very difficult to reach them again. So this is like we are not able to reach around 20% of our patients. I really don't have a solution for this. How can we solve in the future? But it is, you rightly pointed out, it is really a big problem. I don't know how others can solve this.
Okay. We will touch base with the participants here. Courtney, can you unmute him?
What?
No. There's a participant who's going to ask a question.
Go ahead,
Yes,
Dr.
sir.
Shifra.
Yes, may I add some few words on what
Yes,
Dr.
please,
Mokonnen has said?
Yes, sir. Please, sir.
Okay. Yeah, regarding oral hygiene and orthodontic care, which is being part of this comprehensive health care at Ekachit Hospital in Addis, our Cleft Orthodontic Unit has prepared a brochure in different language, because we have different language in the country. So we supply them with these brochures to those family who can read and understand. And we also have contacted some toothpaste manufacturing companies like Colgate and Signal. We got some toothpastes. We have also got toothbrushes. We demonstrate them while they are coming to the center for consultation or treatment, and also provide them with these toothpastes and brushes, and even tell them how to use a local this miswaki. In Ethiopia, there are many people using this traditional tooth brushing technique. To those whom we cannot provide toothpaste and brushes, we also advise them, because these toothbrush and toothpastes are not lasting long. And we also do for each patient who are coming for screening before surgical procedure or dental procedure. We have oral hygienist, and the oral hygiene care is being given for every cleft patient who are coming to our unit. So before surgical procedure, even before we start orthodontic care, they have to be visited by our oral hygienist, and they will be given care in our setup, scaling and cleaning and so on.
Yeah. Okay. Thank you so much, sir. I would like to ask one question to Sanawan from Thailand. So Sanawan, do you have any information from how are you reaching the families in Thailand in this context as a NGO? What are the activities which you have done to communicate to them? How are you doing reassuring them the care, and we are here to support you? What are the steps taken by you, Sanawan?
Thank you. We developed the we use the telephone, not the smartphone. We use group line. Group line is a kind of mobile application similar to WhatsApp and also Facebook. Okay. And then, but for selected one, and one who cannot have a smartphone, so it's just normal phone, we reach them. That's the way we do.
Okay. So, how are you preparing your team, to go ahead and then start the services back in different parts of Thailand and Myanmar? What are the steps which you have taken?
Actually, we have developed the telespeed since our cases is scattered all around, in Laos, in Myanmar, and along the border in Thailand. And then it's difficult for us to reach them for the speed therapy. And then even we developed the mobile unit. But when COVID came, we cannot go out. And then before, just, a few months before that, we developed telespeed. So it's meaning that for the remote. And then when the COVID comes, so we develop more. So during COVID, the speech bank authorities in Chiang Mai, which is 183 kilometers from the border, and then so we can connect in from Chiang Mai to 180 something kilometers, and from in Myanmar and also in Laos. So we can continue. We organize twice a month. I think I feel it useful, but I still interesting in what the Dr. McKinnon do on radio. And I made my comment that that's also good, nice.
Okay, thank you so much, Panawan. I think our speaker Sauda is also here. Can you hear us, Sauda? Yeah, you have to unmute, Sauda. Can you unmute her? Curtly. Hello?
Hello.
Oh, it was wonderful listening to your presentation. And
Yes.
Can you please talk about the work as a program officer? How did you mobilize your entire team? How did you mobilize the patients towards, coming and accepting cleft care? It will be wonderful to hear from you.
First of all, we have a cleft team that is headed by the head of reconstruction and plastic surgery, that is Dr. George. He mobilizes us, we discuss issues, and we come up with solutions. So as I presented, the different ways of how we strategize when we realize that our patients were not being reached. So we decided to take on the different responsibilities. The nutrition team, working together with the programs, came up with a message that was shared to the entire cleft team, and and agreed upon. Then we translated it in the different languages. Then we ran it on the different radio stations, meaning we had a wider coverage by translating and running it on the different. So we also use the mobilizers. They are very crucial. They're like village health team members. These are people who are respected for creating advocacy on the different activities, mostly that government touches on. So we use these same people to reach out to our cleft patients because they are trusted. So when they talk to these cleft caretakers, these mobilizers are really, really respected. That is how we manage to persuade. And when they come to KOSU as well, we continue to talk to them. The first stage is they see a social worker, and social worker does an assessment, finds out the problems that the caretaker is facing. So they do a lot of counseling. A lot of counseling, and share experiences with these new mothers and fathers. So in that way, we are persuading them to come back. And also when, like I told you about the t-shirts, when a t-shirt is given to that person who is respected in the community, and people are able, is this service provided at this hospital, they will automatically come to this person, and this person is able to explain very well about the program at the hospital. So those are some of the ways that we have managed to be able to bring back our patients to for further comprehensive cleft care.
Okay, that's great. So the point which almost all three of you, talking about now, how to move from fear to faith. There's a fear of unknown, and to have faith in the comprehensive cleft care team, and there's a lot of learning which we need to do. Is there anyone in the group who would like to share their experience, who is from a different part of the world, who is working on addressing these challenges? We'll be happy to take one or two points from the participants here. You can raise your hand, we will watch out for you, and then we can unmute for that. It will be an opportunity for us to listen to you all.
Please feel welcome to unmute yourself as well.
Yeah.
You have something to add.
I can wait for a minute to hear from one of you, and then maybe if not, we can move to the other part. Yes, Lakshmi.
Suraj, I have a question to Dr. Maria. I've seen her videos used on Zoom meeting, or it could be on the laptop or a computer. But most of the time, what we see with our patients is they have only mobile phones. Laptops are not available with many patients. So I just know one thing, like this software, did she use it on phones also? Is it like, can it be downloaded and can be used on the phone? Some of the patients, some of the children were using phones in some of the pictures she showed. So any regular phone also can download that software, or if it's only the Zoom or only the laptop. If yes, many of the patients in our country, at least, they don't have laptops at home.
Yeah.
The graded cleft lip and palate patients. So can she suggest some?
Yeah, sure. Dr. Samplona, all yours.
So yes, we are able to download, the material, or even to connect to the telepractice via Zoom. We're using Zoom, so they can do it from the phone. And yes, most of our families are doing by phone, by the mobile,
Yeah.
So yes.
So the device, she's saying that she's used a mobile phone, and the software or the platform which she used is to connect families is Zoom.
Okay, they have to download the software which she sends on the
It's
Zoom.
the Zoom
Or,
platform. I think she shared screen. Am I correct,
oh,
Pamplona?
and then just do. Okay. After that, they cannot use the software.
Yes, I mean the material. Yes, we are sending it via when they have email, but not all of them have.
Okay.
But we can do it by WhatsApp. So we have a WhatsApp group for each group. So, for example, I use one storybook or one song, and then I send it to the group in order the families to have the material for keep practicing. So yes, they have it there in the WhatsApp group. And for the telepractice, they can do it like right now via Zoom. So they just get in the session and out of the session.
Okay, great.
Okay, sir. To Dr. Maria.
So because, yes, Dr. McConnell, please go ahead.
How was the chore rehearsal done? That's my question. During this time, the chore.
No, it's okay. Can you say it again?
You said there were a chore rehearsal.
Choirs?
How do we do that?
Yes.
Yeah.
So we have we just choose which songs are we going to practice. So what we have been doing is to put the song, and then specific parts of the song, they can act the song or they can use some things. For example, if we have one song that is about the pizza, the kids doing pizza, for example.
I'm sorry, can I make my question clear? Is it for a single family or how is that? I saw in the picture many children. Is it from a single family or how is that?
Yes, so we like share the presentation. We share the video of the song, and then we ask them to sing with us, and then we stop in a specific part and work on articulation, or ask them to do some things or whatever. But basically, we're sharing the screen with the video, so they can be singing and practicing.
So this can be applicable for a family, because we cannot bring them together during this COVID time. The children will not come together. So it have to be in their family.
In the family and in the session, I mean, they will have the songs. All of them have the songs to practice with the family, with the brothers, or whatever. But we have a session just like this, a 1 hour session to practice the song together with other kids.
Yeah.
So is it video communication, or a child within the family will be helped by the family looking at the video and so on? Because you cannot bring the children during COVID time. The children will not, with cleft will not come together. They have to be in with their family, so they have to separated.
Yes, so each kid is at home, mainly with a relative or with a older brother, something like that. But we get together like this in a Zoom reunion. So we are able to practice together for 1 hour, and then they can practice or no with the family.
So to put it in technical way, you do both online and then offline technology, where you are there as a therapist real time, and the children are there with you, learning from you. After that, the video is shared with the individual family so that they can practice after session. Did I get it right, Pamela?
Yes.
Okay. Yeah. So I have one question. What is the knowledge of the family in, with respect to operating technology? How much time do you spend talking to them about learning this technology? Because it's very important, right? Not everybody is familiar about how to download Zoom, how to download Zoom, where is mic, where is camera. How much time do you spend average,
Mainly, I mean, you'll be surprised. I was surprised, but some families last like 2 sessions
Okay.
in order to learn. The most difficult part for me, I mean, they can download the Zoom easily, but
Okay.
most difficult for me is like educating in order to respect, because we're working in groups. So they are sometimes, I mean, the mother is talking to the kid, say it correctly, do it loud. And I am like, okay, so everyone who wants to talk, raise your hand, or I will, I mean, in order for everybody to listen to the song at first, I am going to put in silence to everyone. So I put the silence, and in the next second, boom, they put the microphone on, so they start talking again. So I am, oh, okay. So we need to be in silence in order. So this is for me the most difficult part, to educate ourselves, all the families as a community, where we need to respect and be in silence, and that is difficult, but we
Yeah,
can do
that's
it.
good, but it won't be applicable for resource-limited countries like ours, because
Yeah.
even the normal family do not have access to internet, and
Yeah.
so the family are not also well educated to use this technology, and maybe applicable in developed countries, or I don't think we can apply this in a country like Ethiopia, where even families do not have a normal telephone, hand telephone.
Yeah. So that's the point which was.
Anyhow, the idea or the way it has been approached, I appreciate. So to those families who can have the education and as well as the facility, that's very nice.
Yes,
to
so
fix
I'm sorry, Suraj.
no, I'm sorry, just a point. To join the dots, this forum is especially to address questions like this: what I don't have, what others have, and we are looking as an introspection of the strength. So you have fantastic mobilizers, you have many other resources where we can connect. And in the plenary session, what Dr. Rupa and Dr. Sarah spoke, that how can we club resources? So you can take the idea of that song and the therapy techniques, and you can, there is a tablet donation camp which he was talking about. You have a mobilizer. Can the mobilizer carry a device which can go to the patient's house? So some therapy is better than nothing. So there can be some learning points for team in resource limited regions where available of human resources can be taken to leverage technology. So it goes hand in hand. So some places where family can start things on their own, where resources are limited, how can we club resources so that we accumulate everything and then try to use best? So always we will be, in different positions. So it's a great forum, and I think maybe you can try these ideas in your region, and then share it with us so that it's better. You have explored radio. There are many regions who have not explored radio at all. So we are learning best practices from here.
Yes. So other things that we are starting is that we are getting funds in order to pay for the data for internet, so they can connect that hour a week or 2 hours a week or whatever they can want. So we can pay for the data. We started to do that for some patients that do not have accessibility to internet.
Okay. Hi, Pam. Do you have a point?
Hi, everybody. I'm Pam Sheeran from Smile Train. I just wanted to share, unfortunately, our staff and some partners from the Philippines, I don't think are on the line, but I wanted to share something similar, that they've been trying to work with local telecom companies to get $1 or $2 free cards so that they could pass them out. And to the patients, again, the actual how they pass them out or how they distribute to the patients, I'm not sure, because that's the challenge around COVID. But they're able to maybe mail them or drop them, or maybe when the patients do come to the hospital, they're able to hand them to them so they can have the therapy back at home. So that's one, I know, solution that's come from the Philippines. And then for actually motivating the families to keep touch through telemedicine, to telehealth, and to attend the speech sessions. There's some local celebrities, which I'm sure, you know, it's just also difficult to always have access to them. But Smile Train, we've tried to connect some of our regional programs to local celebrities as we can, and they've helped with joining the speech sessions in group and reminding everybody about safe practices around COVID, right, washing hands, keeping distance, and encouraging them to stay practicing their speech. And that's also been, I know, something that's seemed like it's really motivating for a lot of the patients to continue getting to see someone they really, you know, admire, a celebrity, to join and encourage them. And for that person, it takes them a couple of minutes and they're able to reach, you know, many, many, many patients. Those are just two quick stories from the Philippines. But thank you, everyone, for sharing all of your amazing work that you're doing and sharing your solutions.
Can I ask you one more question?
Sure, as many as you like.
Yeah. So how do you think the NGOs are responding to the situation? Because there's a lot of support which requires, you know, to bring the professional group together so that they can go and deliver best practices there. So how is this situation, you know, affecting the NGOs and all of that? Do you have any information on that?
I think there's a couple of ways to look at that question. Some I've tried briefly touch. From Smile Train's perspective, I think a lot of our supporters are really keen on, the ones that love Smile Train or love the cause and want to be able to help, you know, support these families continue to get care. They want to continue giving even during this time. And so they want to see the innovative solutions. They want to see that we're able to still support our partners so they can do creative work on the ground to still be able to reach patients. So from the financial side, you know, Smile Train, it's been actually really encouraging to see how much support there still is for these types of innovative solutions that can reach patients during a difficult time. Now, for the way Smile Train works, you know, the way our programs work in the field, we had to really adapt very quickly when everything started being shut down. We launched a new grant program called a special grant program that really didn't have as many processes in place, or it really didn't have much reporting in place to make it easy for partners to be able to get funding so they could do this online type of therapy and support for their families. We didn't want anything to hinder them from moving quickly. And, you know, a lot of these efforts are pretty low cost anyway, but they needed some sort of support. So we just had to move really fast and create more grant programs that were more flexible and that didn't have, you know, weren't as heavy when it came to reporting outcomes. For partners that did have strong processes in place for reporting outcomes for speech therapy, orthodontics, nutrition, we encourage them to continue to do that in our online medical database. But for those that were getting just started with telehealth, we just said, get started. Here's some seed funding for that, and tell us how it's going. You know, we have weekly emails we were sending to all partners that were sharing these types of best practices. And we just said, you know, keep letting us know what you need. I hope that answers your question, Suraj, but we just tried to be flexible and adaptive.
Yeah. That's a question which I don't think we can answer in one session because the situation is so dynamic. New challenges comes up every day. So I think, you know, there's a lot of gratitude to NGOs like, you know, Smile Train Transforming Pieces, where they keep us connected, you know, in sharing information and sharing best practices. Thank you so much, Pam, for the information which you have provided.
Yeah, great. Anything. Congrats again for everybody for this session.
So is there any dental professional who is there in this group who would like to share information about, or a clinical psychologist who play a very important role, or a nutrition in this group who would like to share their best practices? Because we have covered a perspective from a surgeon, from a program officer, from a speech language pathologist. If there's anybody in this group who has information from a nutritional perspective, or a dental perspective, or a clinical psychology perspective, we will be happy to hear.
Mm-hmm. Well,
oh, sorry. Please go ahead.
Yeah. Is there somebody who has some interesting information or learning point to share? We'll be happy to.
Yeah,
It looks like Elizabeth has a point.
Yeah, please go ahead.
Yes, hi everyone. I'm Elizabeth, working with Operations as the program coordinator. So in Malawi, we are running a nutrition program.
Okay.
What we are doing, before COVID, we had at least 4 centers in almost each and every region of Malawi. Those are the nutrition centers. So the program, we register all the patients who are under 5 because we want to make sure that the time they are, those children are already at risk of malnutrition, and want to make sure that the time they receive surgery, they are fit. So when Malawi announced that, when we had the first case of COVID, we did a countrywide nutrition program whereby we did the assessment of all the children, checking their weight, height, and the homework, and then we provided nutrition supplements to the patients for 3 months. And after 3 months, like last month, because we didn't want our patients to come in cluster, we decided to take the services close to their communities. So what we did, we increased the number of nutrition centers. So we could go for a day, we could go to different nutrition centers close to the community so that our patients do not walk long distance. And at first, we combined COVID message with nutrition. So we start giving COVID messages, and we provide face masks to all the patients and all the guardians. And then we had some local donations. We provided some soap so that our patients can do hand washing, and we did a demonstration of how to wash hands. And then after that, we do the assessments, the nutrition assessments. So those patients who have, according to the Malawi nutrition guidelines, those patients who are severe nourished, we refer them to the hospital. We make agreement. In most of the hospitals, we have medical volunteers. So we link up with the medical volunteers of that facility so that they make proper follow-up of the patient as we are sending them to the nutrition center at the hospital. And most of the food supplements that we give to the patients is the rikuni pala, the milk, and also nutrition education to the mothers on how to take care of their children. Of late, we also run a training program. We have trained some nutritionists from different district hospitals, but they were just a few, so that we still abide to the COVID measures. So the aim of the training was to make sure that as they are in their districts, they should be able to assess the patients as we are not there, because we are doing the 3 months. As we are not there, they should be able to, if the patients have got any other problem, the nutritionists in those district hospitals, they should be able to provide support to the patients within their communities. Yeah, okay. That's it.
So during the previous session, there's a lot of stress on the mental health. Okay, so is there any team concentrating on mental health of families, giving specific sessions on reassurance to the family? Are there any dedicated efforts, taken in any part of the world, or any of the participants have done any work on that? Mental health and reassurance for families.
So we're in Malawi, we have, someone is on. We have just planned to have, when we are doing the nutrition assessments, like in Malawi, we have psychologists, the child life specialists, the ones who provide psychotherapy before the patients get the surgery. So we are planning to have those accompany the nutrition team, go to the nutrition center and provide psychological support to those mothers and to those babies, because we have canceled the missions, so they are worried that they will no longer get the surgery. So we opt of including Those child life specialists provide psychological care to the patients. Thank you.
Okay. Is there anyone in this group who has worked with the government in providing suggestions or ideas, specifically towards cleft care? I know cleft is not the primary, but is there any other country who has set an example of, representing our case to the government, the respective country government, and, stressing the need for reinitiating cleft care services? Is there any work done, or is there any model to be shared?
Sorry, Suraja, we're out of time for this session, so it's an important question for sure, but I think we'll hold it, and hopefully anyone who has any important insights there can bring it into our next multidisciplinary roundtables.
Yep. Okay, so we are at the end of the session?
Yes.
Okay, so thank you so much for all the speakers who were with us for the last 1 hour or so. There's a lot of information to share and we have learned. And I'd like to thank all the participants who are in this group. I think if we all touch base with the CCC team, there's an opportunity for us to connect, ask questions. There is a dedicated platform to share best practices and ask questions. So it will be great if we can touch base and continue our discussions in that platform. Is there anything which I should add? Courtney?
Thank you so much to our wonderful hosts and panelists and for everyone's participation in the session. As you'll see here, we're just starting a quick 8-minute break or so, and then the next roundtable 2s will begin. So please do select which of the 4 sessions you'd like to partake in, and you can enter the same way you access this call here. But in the meantime, have a stretch, grab a glass of water, use the washroom, and we look forward to seeing you in a couple minutes in roundtable 2.
One more point, Courtney. Any of us can be reached through the Tico chat. There is an email option. When you type a message, the respective person can get it. So you can look out for the participants who are in this room and send a message to them if you have any specific questions. So this will help us to connect and stay connected, with this bigger group.
Yeah, it's a great point, Suraj. And we also have 2 dedicated scribes that have been taking notes throughout the discussion. So we'll be able to prepare an outcome report based on some of the key points that were raised here, and we'll be sure to circulate that to all conference participants afterwards. Thank you, everyone.
Thank you all.
Really appreciate your time, and we'll see you soon in the second round.
Yeah, thank you so much.